spontaneous airway management, awake and non-drowsy, comfortable and pain-free, and finally hemodynamically stable. Hello and welcome to my YouTube channel once again. Today we will be discussing about critical care and its structure. The structure of critical care should be known by health professionals because it is necessary to consider what level of care a patient will require, and you can put patients accordingly. And for doing this, in order to do this, you need basic knowledge which you can acquire through this video. So let's begin. So basically in critical care provision there are 4 levels which extend from level 0, level 1, level 2 and level 3. Level 0 basically denotes normal ward where we see many patients and on-call doctors doing their duties. If we move further, there is level 1 which is known as enhanced care. In enhanced care, the nurse to patient ratio is approximately 3:1, and the purpose of enhanced care is to keep patients monitored. Well, is level 2 which is high dependency unit where nurse to patient ratio is 2:1, and the patients who have developed single organ failure are usually kept, but the requirement is that the patient should not be ventilated. If we move forward to level 3, which includes intensive care recovery units, the nurse to patient ratio there is 1:1, and the patients who have developed multi-organ failure or require ventilation are usually admitted here. So 4 levels of care is provided, extending from level 0 to level 3. A basic knowledge of these levels should be known because it will help health professionals to know about the patient's probable level of care required. If we move ahead and talk about the recovery units, which is a level 3 care, we know then when a patient has undergone some sort of surgery, the patient is not directly transferred from OR to ward. The patients are usually kept in recovery units before being shifted to ward. The purpose of these recovery units is to detect effect of anesthetics and to detect early complications of surgery, which include hemorrhage and severe pain. But if you keep a patient in recovery units before being discharging to the patient, there is a criteria when you can discharge the patient to ward, which includes spontaneous airway management, awake and non-drowsy, comfortable and pain-free, and finally hemodynamically stable. There are other criteria as well, which includes no evidence of hemorrhage, which we have already discussed, that when a patient is put in recovery unit, the purpose is to detect continuing effects of anesthetics and to detect early complications of surgery, which can be hemorrhage. So there should not be any evidence of hemorrhage, and this criteria, which is known as SACS criteria, which includes spontaneous airway management, awake and non-drowsy, comfortable and pain-free, and hemodynamically stable. If patient has these all 4, patient can be safely discharged to the ward. Then there is another level of care which we have discussed in level 2, which is high dependency unit. It is appropriate for patients who require more input than a general ward, or the patients who have organ failure but do not require intensive therapy unit ITU or ventilation. The purpose of putting patient here is to give benefit to the patient because of higher ratio of nurses to patients as compared to general ward or enhanced care. So here you can provide higher level of monitoring and therapy. If we move further ahead, there is intensive therapeutic unit, which is a level 3 care. If we consider the ITU beds, especially in UK and other parts of the world, they usually comprise of 1% of all beds. There is a criteria that an intensive therapy unit should have at least 4 beds, but usually it contains 8 to 12 beds. Intensive therapy unit should be near or on the same floor as BART, which includes blood bank, accident and emergency, radiology, and theaters. There is a criteria when you can admit patient to ITU, which includes the patients who have to undergo elective emergency or prophylactic treatment, the patients who are having some potentially reversible conditions, the patients who require high level of monitoring, for patients who require mechanical support of organs, which can include ventilation or dialysis, and the patients who have more than one organ failure. These patients are usually admitted to intensive therapy unit. When patients are discharged from intensive therapy unit, it includes The patients can be discharged to HDU, high dependency unit level 2 care, which can occur sooner than to a general ward. The discharge from intensive therapy unit is usually decided by senior intensive therapy unit staff, and care is handed over to specialty team. Then there is a concept of poor outcome in the critically ill patient. So when you are providing critical care management to a patient, you have to be very much clear in deciding which level of care a patient requires, because one of the criteria for poor outcome in critically ill patient is late referral to intensive therapy unit. So make sure that you refer the patient to intensive therapy unit as soon as patient requires. There are three things which are general and are considered the reason for poor outcome in the critically ill patients, which includes late referral to intensive therapy unit, inadequate ward care, and cardiac arrest. And if we talk a bit more about cardiac arrest, we know that it is known that around 80% of cardiac arrest cases could have been predicted, and if predicted, could have been saved. So in the critical care, we have 4 levels: 0, 1, 2 and 3. 0 includes normal ward, which includes in-ward patient, which you can remember by knowing as normal ward. The level 1 care is known as enhanced care. In enhanced care, the nurse to patient ratio is 3 to 1. Monitoring is being done and so on. Thank you for watching.